to the registration team out at the desk, most of you have been able to make the trek in from the outer regions and get through all the flood zones and things. So we do appreciate your perseverance in making it to our 5th annual the Resource Center Symposium at Chautauqua. Just to give you a quick background of the Resource Center, most of you know us and know us well, but we're a comprehensive organization offering an array of services to people primarily with developmental disabilities in the Chautauqua County area. We provide the traditional IDD services as well as a broad array of clinical services, both in the Article 28, Article 31, as well as the Article 16 clinics. In those clinics, we provide primary care, dental, speech, occupational therapy, physical therapy, audiology, podiatry services. We also provide psychiatry and a broad array of social work services. We have over 500 people that we serve in health homes, and we also provide a broad array of employment services to over 600 people in Chautauqua County. In terms of where the Resource Center's been, we've been on the cutting edge of system transformation and preparation for managed care. We've previously been awarded an MRT grant through OPWDD for providing opportunities for less restrictive housing that realized a cost savings to the system of over $300,000 and resulted in over 220 individuals moving into less restrictive settings. In addition to those 20 individuals, we had about 19 others that we were able to move into community-based settings in 2014 alone. We were also recently awarded a Department of Health BIP grant to collaborate with Lutheran, which is a long-term care facility in the Chautauqua County area, to improve medication management and diabetes care services to enable individuals to stay in their homes and be served in their homes or community-based settings. Projected cost savings upon completion of this project is targeted at over $1 million, and I understand we've already realized close to $900,000 in savings through that project. In addition, we've been actively engaged in the district planning process in Western New York and are currently a key partner in the delivery of health home services, as I spoke to earlier. As an organization, we continually strive to not be comfortable with the status quo, which is why we're here today and why we have the symposium at Chautauqua. What better place to challenge the status quo and our thinking than Chautauqua, the Center for Learning, which is for centuries has been recognized as a place to come and broaden your thinking, learn, and challenge. I'd like to thank you all for coming. We have a number of distinguished guests in the audience, as well as distinguished speakers who I know will challenge the status quo, challenge our thinking. We may not like everything that we're going to hear today, but it's those things that we need to do to better ourselves, to sharpen the services that we provide to individuals in our communities. Just as a few housekeeping items, the bathrooms are out through the lobby, on the other side of the lobby. We did not schedule breaks into the agenda, as you've seen, but please feel free to get up and do what you need to do, grab some coffee or things as the speakers work through the agenda today. We also plan to serve lunch at 12:30, and there will be an art show at 5 o'clock showing the works of our very talented artists in our day hab and our traumatic brain injury programs. So again, thank you so much for your attendance, and we look forward to hearing from our distinguished speakers today.
Good morning. It's my privilege to introduce our first speaker, Jason Helgerson, New York State's Medicaid Director since January 2011. In doing a little bit of research prior to today, I found a statement Governor Cuomo made when appointing him that said he wanted Mr. Helgerson to draw on his experience in Wisconsin to rein in Medicaid spending in New York. Jason was then quoted to say, he really wants to pursue radical reform. This is just not trimming around the edges. I believe we can say that he's done more than that. Along with just trimming along the edges, Jason has been responsible for bringing a whole new language of alphabet soup to New York. Let me touch on the new alphabet Jason has introduced us to, or I'll try. So we have $8 billion to reinvest in DSRIP from MRT savings that New York may spend $500 million in FFP for IAAF, but IAAF must work with the PPS through the VAP. Then, of course, the hospitals can use the PPR, the PQI, the PBB, the PDI to help reach their goals. And then we can always take the ship to the DISRIP, leveraging the PCMH through the HIT, with the RIO being supported by the SHINY. As we all work towards our MU2, ICD-10, DSM-5, PCMH 2014 by DISRIP Year 2. And once we have all figured out DISRIP and how to figure out working with our PACs on mandatory 2AI, some of us get to dive into the 2DI, which is affectionately nicknamed the 11th Project, to serve the UI, the NU, and the LUs. And we can't forget everybody's questions: how will our ACOs and IPAs partner with our PPSs? But rest assured, when we get really stuck and we need help, we can just give an SOS to the DST to get KPMG, LLP, ASAP. So, thank you for the new alphabet. Jason also serves as the Executive Director of New York's Medicaid Redesign team. In this capacity, he leads Governor Cuomo's effort to fundamentally reshape the state's Medicaid program in order to both lower costs and improve health care quality. Prior to arriving in New York, Jason was Wisconsin's Medicaid Director, and in that capacity, he administered the state's nationally recognized Badger Care Plus and Core Plan program for children and families, Senior Care, Food Share, and Wisconsin's Chronic Disease Program. Jason was also the principal project sponsor for Badger Care Plus, former Wisconsin Governor Jim Doyle's signature healthcare initiative. Through this program, 98% of Wisconsin residents have access to affordable health care, including all children. Jason served as the Executive Assistant Policy Director to the Secretary of Wisconsin Department of Health and Family Services from February 2005 to March 2007. Prior to this, Jason served as the Executive Assistant to the Wisconsin Department of Revenue. And prior to joining the Doyle administration, Jason served as the Senior Education Policy Advisor for Mayor Ron Gonzalez of the City of San Jose, California. And in this role, provided advice and counsel to the mayor on all issues related to children. Before joining Mayor Gonzalez's staff, Jason worked for the Milwaukee Public Schools, where he served as both the chief lobbyist for the district and as a deputy budget director. Prior to taking the position with Milwaukee Public Schools, Jason worked for Milwaukee Mayor John Norquist, where he was the Education Policy Advisor and served as a senior official in the Mayor's Budget Office. Jason received his Master of Public Policy degree from the University of Chicago in 1995, his BA in Political Science from American University in Washington, D.C. in 93, and Jason is also a Clinical Associate Professor at the State University of New York at Albany School of Public Health. So let's give a warm welcome to New York State Medicaid Director Jason.
First off, I've been introduced quite a few times in the last 4.5 years, but I have to say that is the most clever introduction that I've ever come across. So how you were able to put all those acronyms together in such a clever fashion, it's very impressive. So also, as you see, I've had quite a few jobs over the years going throughout my career. So, but I feel like my career sort of has taken me through a whole series of things, including human services and education, and now here working on healthcare in New York. And I think that one of the things I've learned in my career is the importance of getting out when you're in jobs such as mine, and traveling the state, traveling the jurisdiction, sitting down with the individuals who really are on the front lines of the various programs that you have a role in administering. So I'm very pleased to be here today. This is my first time to this particular part of the state. While I've been to Buffalo on many occasions, I have not had the opportunity to come down here the hour and a half south to be in this area with all of you, and I'm greatly appreciative of this opportunity for me. And being at this lovely place, this lovely community, I've been kicking myself for not having come long ago. So in terms of today, I'm going to talk sort of about three things, assuming that the weather allows us to continue. First off, I'm going to give a little bit of an update in terms of Medicaid redesign. I won't spend a lot of time on it, but we've been at this now for 4.5 years, so we actually have a track record we can talk about. And so I think talking a little bit about the past sort of helps set the stage for what I'll spend the majority of my time talking about, which is delivery system reform, or DSRIP. And perhaps most importantly about payment reform, which is really the focus of what I've been talking about as I've been traveling around the state recently and trying to raise awareness of this exciting new initiative and why the move to payment reform is really so essential for providers all across our state. So in terms of Medicaid, we're now over 6 million people, and I'm also glad to say that while when I started we had the largest Medicaid program in the country, we are no longer holders of that title. Very happy to give that title to the state of California, who has now eclipsed us. We spend approximately $59 billion a year, more than $1 billion a week. And so our program is important not only for the healthcare services that are provided to those 6 million people, but we also are essential not only to the economic viability of the healthcare sector, which is about a sixth of our economy in New York State, but actually to the entire economy as a whole. And I think for those of you who maybe follow the ups and downs of the economic cycle in our state and our country, you see that one of the more stabilizing elements of our sector, of our economy, I should say, is the healthcare sector. And Medicaid plays an important role in that as well. So in terms of when we started, 2010, these are some statistics that we used when the Medicaid Redesign team first met in early January of 2011, shortly after the governor took office. We were a program that was, not only were we about a third or a little more than a third of the total state budget in New York State, we were a program that was estimated to grow year on year at about 13%. This was a time when actual state revenues were expected to decline because of the Great Recession. The governor inherited the worst budget deficit in state history coming into office in January of 11, and really sort of set the stage for why we had to do Medicaid redesign in terms of fiscal policy for the state of New York. But I think what's also important to point out is that at the time, New York, in my view, considering the fact that the largest Medicaid program in the country, we were spending roughly twice the national average on a per recipient basis, we really were not getting the kind of results you would expect for that level of investment that was made by our taxpayers. We ranked 50th in the country in avoidable hospital use, which I'll talk about as an extremely important measure for what we're trying to do with regards to Medicaid redesign. It's a measure that, in my view, is a sort of an indictment of the overall delivery system. And these are individuals who are in hospitals receiving services when they really shouldn't be, if we just did a better job as a delivery system, meeting their needs in the community. We were ranking in the 2009 study, as you see on the right from the Commonwealth Fund, we ranked dead last in the nation. We've improved slightly since then. We're now about 34th in the country, but we still have a ways to go. And that's why the most important measures in the DSRIP program are directly tied to reductions in avoidable hospital use. Overall, in terms of the quality of our healthcare delivery system, we were about in the middle of the pack. So despite such a large amount of expenditure in the system, we really weren't getting the kind of results you'd expect. Certainly we would hope that overall our delivery system would be performing better than 21st. And then lastly, about the challenging environment that was faced by the governor when he took office, was that Medicaid had become the ultimate political football of the New York State budget process. Governors proposed significant reductions, cuts in provider reimbursement, other program changes. Legislature, in response to very vicious attacks by the healthcare industry, would oftentimes basically stop some of those reductions, but really sort of paper over some of the structural problems in the program and sort of kick the can down the road, so to speak, in terms of real meaningful reform and structural change. And so it was a very, very challenging environment that the governor inherited, and that was really at its core why he decided to create the Medicaid Redesign team. The goal here was to actually create a different process for designing and reforming the program. It was to try to bring together the various stakeholders who had sort of sat on the sidelines and attacked in the past. We asked them to be part of the solution and develop a plan. And to the surprise of many, that process worked. Worked in two phases. One was a 2-month process, very intensive, to design a series of initiatives to achieve a very aggressive cost savings target. $2 billion from a state spending standpoint, $4 billion in terms of gross spending was the initial target. Those stakeholders coalesced around 79 recommendations that accomplished that goal, and those recommendations actually, not only did they achieve the approval of the Medicaid Redesign team, the governor accepted them as is. He put them in his modified budget. The legislature approved 78 of them. Some of them with some tweaks, but generally the plan as developed by the MRT became state law. Then the MRT completed its work through the end of calendar year 11 with the plan, whose cover you see there on the right. That plan has, in essence, been implemented, or is still, there are some steps that are still in the process of being implemented in the next 12 to 18 months. But if you go back to that plan, which is still available on our website, I think what you'll see is that we have stuck to that plan very closely over the last 4.5 years. And I think one of the advantages of our environment is that we started with a direction and we've stuck to it. Rarely does government actually do that. So oftentimes it operates in fits and starts, it changes direction, changes priorities, and the problem when that happens is that it's very hard for the provider community to see where the future is so that they can prepare for that future. And so I think a lot of what I'm here talking about and the steps that I'll spend most of my time talking about are things that actually build upon that first initial plan and highly consistent with, and in fact are made possible by what has been done so far to date. So in terms of our key reforms, the global spending cap, first of its kind in the nation, brought fiscal discipline, transparency to a very complex program. We now report out on a monthly basis. This also gives us the opportunity to know not only what we're going to spend this year, but we have an appropriation in state law for how much we're going to spend next year. Tremendous innovation from a Medicaid policy standpoint to actually have an ability to see the future and make plans and decisions not based strictly on current priorities. Next is care management for all. We have a couple steps left in moving all of our services out of fee-for-service into managed care. Big steps coming this year is the move of behavioral health services in. A lot of work has been done, tremendous changes. And Mike Hogan, who you'll hear from later today, was the commissioner at OMH during the early stages, was a member of the MRT, knows full well of how much the behavioral health community and their views on managed care has evolved, and very excited to launch really the first of its kind in the nation health and recovery plans, which targets high needs people with regards to behavioral health needs. First of its kind specialized managed care products specifically for that population. So we have a couple important steps left there. Patient-centered medical homes, greatly expanded, 1 million more Medicaid members, moving into patient-centered medical homes, benefiting from high-quality primary care. A very important element also of DSRIP is the expectation that all primary care providers by the end of year 3 of the DSRIP demonstration will meet a level 3 patient-centered medical home criteria. Basically, our goal here, and DSRIP is our vehicle for it, is that every Medicaid member will have access to the high-quality primary care that's associated with being a patient-centered medical home. Also, health homes. Glad to hear that our hosts here today are using that program so effectively. I was hearing about it a little bit last night about all the care managers that have been brought on board targeting a high-needs population who have a lot of challenges navigating the delivery system. It's an important building block for DSRIP. We need to integrate those care managers into our efforts to reduce avoidable hospital use. And so far we feel it's been a program that's been successful in the sense of it has shown and demonstrated reductions in avoidable hospital use, has reduced ER visits, but it's still a program that's continuing to evolve. And then lastly, the social determinants of health. And I think this is a key theme that we also need to emphasize moving forward, is that all of us collectively, and the performing provider systems in particular, need to see the greater needs of the population they're trying to serve than just their health care or maybe even their behavioral health type needs. We need to think broadly about what we can do to address the social determinants of health, whether those are the challenges and the problems associated with concentrated poverty, whether it's the challenges associated with unemployment, the challenges associated with substandard housing. All of those things contribute, in fact, oftentimes are more important to the health status of the individual than anything the individual healthcare delivery system or any member or provider within that system can actually do. We are leading the nation in some of these areas, but we need to do more. For instance, we're spending $100 million a year on housing. for high-needs Medicaid members. That housing assistance comes in the form of rental assistance, it comes in the form of services that are co-located with those that housing, as well as even capital to build new housing or to redevelop housing for the population. But there's more to be done here. I always remember a statistic that I heard very early on relative to something that Mike Hogan said about people with significant and persistent mental illness. That 80% of that population is unemployed in New York State. And yet at the same time we know that meaningful employment for that population can significantly improve their behavioral and physical well-being. And so we need to embrace the social determinants. We need to embrace things like housing and employment if we're actually going to really improve the lives of the population. So in terms of spending, we now, after 4 years into it, we can actually show what Medicaid Redesign has done. This is total Medicaid expenditures dating back to 2003. So you can see in 2011 was where we began. This is on a calendar year basis. So these statistics are through the end of calendar year 14, for which we now have a complete set of data. As you can see, basically for the first 3 years of MRT, we've flatlined, in fact, reduced spending in the program. We've seen now an uptick in 14, and that's associated with the Affordable Care Act. Affordable Care Act added about 500,000 people to the Medicaid program. The good news is that most of that cost covered by the federal government. So that's what's associated with that increase there. But significant amounts of cost savings achieved as a result of basically virtually flatlining the growth rate in the New York State Medicaid program prior to the implementation of the Affordable Care Act. Here's my favorite chart. This is spending on a per recipient basis. Since Medicaid Redesign began, we've added almost 1.5 million people to the Medicaid program. That's 4.5 years. Significant growth. So at the same time we held it flat in total spending, we increased the program. And the only way that math works is you got to reduce your spending on a per recipient basis. And while we did have some direction going in our behalf prior to Medicaid Redesign, you can see that we greatly accelerated the reduction in per recipient spending. While we don't yet have nationally recognized sort of comparison statistics available, I said we used to spend twice the national average. I think when we do have those comparison statistics, I think we will compare much more favorably. In fact, now on a per recipient spending, we're spending less than we did, you can't see it on this chart, less than we spent in 2002. So we feel like we have bent the cost curve. Our global cap does not adjust for individuals' number of people enrolled in the program. So we've had no choice, but I think it's a sign that our program is becoming more cost effective, serving more, spending less on a per recipient basis. So in terms of what that Medicaid redesign did and our ability to ensure that the program was financially viable, not only do we have to do that for our own taxpayers and to sort of, I think, show them that we could be fiscally responsible, but we also had to do that for the federal government if we were ever going to get our waiver approved. In essence, the waiver that the governor negotiated with the Department of Health and Human Services allows us to reinvest basically about half of the federal savings that is being generated as a result of the Medicaid redesign efforts. And so that was a key component. We were able to show fiscal discipline, we were able to show significant federal savings, and then go back to Washington and make the case that some of that savings, half of that federal savings, so every time we save $1 for our taxpayers, we also save $1 for the federal government, that we should have those dollars available to reinvest in the delivery system, to make structural changes in delivery that will not only help us sustain our gains in terms of reductions on a per recipient basis, but really address more of the structural problems that lead to things like being 50th in the country and last in the country in terms of avoidable hospital use. To invest in new strategies, to invest in new efforts to improve the quality of care for particularly some of the highest needs Medicaid members. And out of those negotiations came, and the vast majority of our reinvestment is for what's called the Delivery System Reform Incentive Payment Program. That is not our name, I did not make it up. It is actually the federal government's name. We are not the first state to implement this program. We're like the fourth, I believe, to implement it. But that said, our version of it is very different than any you would see in any of the other states across the country. So whether you looked at Texas, whether you looked at California, you looked at New Jersey, and there are other states who are coming down the line who are looking at us very, very closely. But our structure is very different. We have a statewide report card. It's not just a bunch of providers working to improve some outcomes, but we're actually trying to restructure how care is actually delivered. And that's a very big difference between us and other states. But the goals are the same as it always has been, so we feel we are being wholly consistent with what we've done to date and why we feel like we're building off a strong base for this new initiative. We want to transform the healthcare delivery system. We want to make it more cost effective. We also want to further bend the Medicaid cost curve. We want to ensure greater access to quality care. We want to improve the quality of care. We want there to be better outcomes. And that's a key thing to understand about DSRIP, is it really is linking payments to providers to outcomes for Medicaid members. That's how the program works. The federal government's very serious about that. It's not about payments for effort or payments for reimbursement of cost. It's really payment for outcomes. And then lastly, also important here, is this is our opportunity to make the healthcare safety net that serves millions of people, many on the Medicaid program, to make it financially sustainable well into the future. This is an opportunity we cannot miss. We have to use these dollars wisely. And I think one of the challenges that I've heard as I've traveled across the state is that there's anxiousness about the fact that while district payments have been made to the PPSs have not yet begun to make payments to downstream providers. And what I would say is when those funds flow, each dollar that comes through, think of it as a one-time resource. While it's a 5-year initiative and $7+ billion is a lot of money, the needs of our delivery system are great. And we need to use every dollar to the maximum degree we can. So in terms of DSRIP and the challenge associated with it is, at its core, what we're trying to do is to integrate the delivery system. We're trying to get providers to come together and think about and deliver care in a very different way than has historically been the case in most parts of the state. What we're trying to do is take a fragmented or siloed delivery system where you have providers off in their own space, working off, and I'm not questioning their intent to try to best serve the patients, but not seeing the other providers who see and touch the same exact patients really as their partners. And in fact, some cases, historically, what they see is they see those other providers as their competitors. And that competition, while it has some benefits in healthcare, I think that it has some very significant negative impacts, particularly for folks who utilize the healthcare safety net, for particularly high-needs Medicaid members. And so what we're trying to do is, in essence, create a system that is basically representative of these terms. We want it to be patient-centered. And when I talk about value-based payment, I'll give you a sense of what's possible in a value-based payment environment in terms of really moving away from a delivery system that's and a set of services that are linked back to state regulations, payment policies, to really sort of thinking, okay, we have a population to serve, how do we collectively do a good job of doing it? That's what it means to become patient-centered, to put the patient at the center of the delivery system and having the delivery system conform to the needs of that patient. Next is transparent. Healthcare is probably, of all the markets one can imagine, it's one of the most non-transparent markets there is. Very little transparency in price, very little transparency in quality, very difficult for consumers, let alone for Medicaid members to be able to try to figure out where best to get their care. We need to find ways to make it more transparent. Next, my favorite word, collaboration, collaborative. We need this to be about how providers who touch the same patients can actually work together, see themselves as a team, not as a group of individuals, working together as a team to meet the needs of the patients. This is going to be one of the most difficult elements. It's historically the way we have paid, the way we've structured our healthcare delivery system, the way we've regulated, has actually discouraged collaboration. In fact, made very fearful, made providers fearful that if they collaborated, if they shared data, that in fact they could put them at a quote-unquote competitive disadvantage, unquote. Yet even though I think most providers that I talk to acknowledge the fact that at the end of the day, a patient is better served when the providers who commonly see that patient are actually talking to each other, sitting around a table saying, what can we do collectively different to actually better serve the needs of the patient? And that's, I think, one of the core challenges we're going to have is how do we drive that collaboration? How do we make it a safe place to have those conversations? How do we better align the incentives and delivery system to reward that kind of behavior? That's really why payment reform is so important. Accountable. Very little money in the healthcare delivery system in the United States is actually linked to outcomes. Most of it's just linked to services. The more services you provide, the more money you get. We want to change that. We want there to be more and more of the money that providers receive actually linked to, did the patient get better? Did their health and well-being improve? In fact, in a lot of ways, I'd say that the current system of reimbursement, or the traditional fee-for-service system, actually penalizes providers when they do a better job. A hospital implements a new and improved patient discharge program designed to help patients better integrate back into the community, better link them to their primary care providers or to the other services that they need in those environments. What happens to the hospital when they do that? Well, they see fewer readmissions, and they see fewer admissions, and as a result, they see less revenue. And as a result of that, they're financially stressed. And so as long as those are the payment incentives that exist in the delivery system, it's going to be very, very hard for us to ask providers to do things, while in the best interests of patients are against their economic interests. I hear frequently, no margin, no mission. So we need to find a way to link the margin to the mission much more clearly. And I think that's a key message point that I have been stressing as I've traveled the state. And then lastly, value-driven. And I think this is a key thing. We want the performing provider systems, these communities of providers, or even within the PPSs, within community, for providers to see themselves not just as periodic providers of service. Someone needs something, they come to you, and therefore you provide it, and you do the best you can. It's really about changing the proposition. It's about providers seeing the community. What does the community really need? And then adjusting what you do to meet those needs. That's about being much more proactive. It's about engaging the patients, and it's about engaging the broader community, the business community, the social service community, the local government community, to talk to them about what, as healthcare providers, collectively you can do working within that broader community to improve the health and well-being of the community you serve. And that's, I think, a key theme that we're trying to build upon and trying to infuse into our continued efforts. So in terms of this, 25 performing provider systems, that's what we call our integrated systems. Large groupings of providers, at their smallest hundreds, at their largest thousands of providers, in some cases large geographies, which I know creates challenges and concerns in communities where they feel like perhaps that district will take away some of their unique community identity. We have to make sure that doesn't happen. It's one of the potential unintended consequences we have to strive to avoid. But we also realize that to do all the things that are associated with this is no small task. These applications were 300 plus pages in length. They're now developing implementation plans. All of those are 400 to 500 pages in length. These are a tremendous lift. There's a tremendous amount that needs to be done, whether it's investments in HIT, whether it's getting all these primary care providers to level 3 patient-centered medical homes status. There's a tremendous amount that needs to be done. So our feeling is that you need some economies of scale to be successful. That said, we also believe the structure allows for communities across the state within PPSs to develop their own unique solutions to achieve the goals of this program. And we have to make sure that that's the case. I think for all folks who are familiar, involved in this, you know it's providers from across the spectrum. The idea is to try to get everyone working together, to have no silos out there that are not included in this particular initiative. And the goals here are tied directly back to what we identified back in January 2011 as our big challenge, which is those reductions in avoidable hospital use. Our 5-year goal is a 25% reduction. Our 10-year goal is to cut those admissions, readmissions, and ER visits in half, which requires us to significantly change how healthcare is consumed. There are communities in the state where roughly half of the emergency room visits today are avoidable. So that means if we're going to cut that in half, that means that's a 25% reduction in ER utilization in some of these communities. That's no small task. So that means that we have to provide services that people not only need, but actually want in the communities in which they live. We have to make healthcare and the types of healthcare we want to encourage, those services encouraged, we have to make them things that the public will want and will utilize that not only meet their needs, but are very easy for them to access, easier perhaps than emergency rooms and other inpatient utilization. So the current state It's a work in progress. This is a huge lift. No one in the country has ever tried anything like this, right? And we're a big and diverse state. This is going to be, as I say to folks, this isn't like the HEAL grant round 27 or whatever was the latest one, where you just simply, the government puts out a document, takes in some applications, decides who should get how much money, sends out some checks and says, report back to us on an annual basis and tell us how things are going. That's not how this works. This is a much more involved effort. The state and its contractors have geared up, deployed resources to support each of these 25 entities and the subparts within them to make, to achieve the goals of this initiative. And is the number one priority of the health department, and will remain so, is the success of this effort. So in terms of DSRIP, we often say that DSRIP and value-based payment are two sides of the same coin. And the reason we say that is, and the federal government feels the same way, is that while we're investing the $7+ billion in delivery system change, in order for that investment to be sustainable, we must change how we pay for healthcare. If we continue to pay for it on a fee-for-service basis, linked back to what are the currently covered services, as soon as the waiver dollars end, at the end of the 5-year demonstration, all of this infrastructure, these new programs, initiatives will begin to wither on the vine. Why? Because most of what we're paying for through the DSRIP program are things that traditionally Medicaid or fee-for-service type of payment regimes would not support. So if we want to retain the gains, we must change how we pay. I would argue that we need to change how we pay even if we weren't doing DSRIP. And the reason I say that is because I believe that the current system of fee-for-service is immoral. And the reason I say that is that because of that system, we have safety net providers all across the state, and inside of those institutions, inside of those settings, we have patients who are in there who are sicker than they should be. And in order for those providers to continue to be viable, those patients have to continue to be poorly served. They have to continue to be sick when they shouldn't be. And I think that is not a morally defensible situation and not a morally defensible way to pay for healthcare in this country, this state, or in this community. And that is, to me, why at the end of the day, even if it weren't for DSRIP, we should be moving to value-based payment. So in terms of Medicaid payment reform, people ask, so, is this a radical new idea that sort of meets with tremendous resistance? So as you travel the state, what are you hearing about value-based payment? Are people responding to this vision? Is New York State sort of out on a leading edge, maybe even a bleeding edge, of trying to do something that no one else across the country thinks is really really a good idea? But just a couple of statistics and a couple of quotes that come out of a survey done by Modern Healthcare found that this is healthcare CEOs from all across the country. 78% said that they believe that value-based payment should be the dominant role of reimbursement. This is a marked change from the past where folks were a little bit more hesitant. They didn't necessarily know if the direction of value-based payment was really moving in that direction, whether that was going to be the future of healthcare. But I think as this statistic shows, more and more across the country of the folks who help play an integral role in administering our system believe that this is the path of the future. It's the path we should, as a country, be moving on. A quote from Ram Raju, who's the head of the Health and Hospital Corp, the largest Medicaid provider in New York City, actually the largest Medicaid provider in the state. Everybody feels that the days of fee-for-service are coming to an end. We need to bring everyone together. We need one glide path. We need to integrate the delivery system. We need to begin rewarding providers for outcomes. We need to start paying not based on volume, but based on the value that is provided by the healthcare providers to the communities that they serve. Here's another statistic. These same CEOs found that basically 93% of them, when polled, said they believe that the quality of care delivered to Americans will actually improve if we move to value-based payments. So not only do they feel it should happen and that and it's probably going to happen, but there's also a strong feeling that it actually, if we're actually successful in implementing it, will better align the incentives of delivery, and as a result, the health of our communities will improve. Another quote here, a little bit closer, from Rochester. I don't see our current system leading to better care. This certainly isn't a slow evolution right now. I think we're bordering on a revolution. And I do think that we are very close to a tipping point. A tipping point which, as I'll talk about in Medicaid, is probably within the next 3 to 5 years, which is as we begin to move away from fee-for-service as the dominant model to an environment where actually value-based payment is the de facto way in which providers in the Medicaid program are paying. And I would argue that our colleagues at CMS are doing the same with regards to Medicare. And then when you do that, you have those two payers together in New York State, you're now 50% of the total. And when you get to that point, I think what's going to happen is whether the commercial environment wants it or not, you will begin to see more and more of the commercial payers adopting it. And I think at some point, the providers, the insurers, the communities as a whole will allow this to just, there will be so much momentum in this direction that it'll just be such a commonplace that people will maybe even forget what the days of fee-for-service were like. We're a little ways away from that. So in terms of the move to value-based payment, our waiver actually requires it. We committed in exchange for that money that up to 90% of our total payments through the Medicaid managed care plans, which is where almost all of our money is, would be value-based by the end of the waiver period, basically by the end of this decade. So that is no small change for a program that spends $59 billion, no small change for the healthcare delivery system as a whole. We are in the final stages, in fact I'm hoping today, to receive a letter of approval of our roadmap, which is available on our website, which explains basically our direction for how we're going to implement value-based payment in New York. So this is the chart that I use to try to explain to folks what it is we're really at the core trying to accomplish with regards to value-based payment from the provider perspective. The problem is what we have on the left, the current state. As providers work together or even in isolation, do different things to improve the quality of care for people in their communities. The example of what I gave before, which was the new discharge planning program that a hospital adopted. What they see is in our current fee-for-service dominant world is the current status on the left. They are doing things to improve the value of the care. They're improving the quality of the care, and they're improving the lives of the people in the communities they serve. But when they do that, they actually see declines in their margins. They see reductions in revenue. And that's because our dominant reimbursement system is linked to volume. So the fewer services that are provided in hospitals and nursing homes and other types of settings, the less revenue those providers receive. What has to happen is we have to migrate to the right side of this chart, which is that when we reimburse providers, as they actually improve the value of care they provide to their communities, we see provider margins increase. That's where shared savings, that's where value-based payment is so essential, is that the providers have to directly see the benefits, financially see the benefits of their efforts to improve the quality of care that they provide. So how are we going to do this? What does value-based payment mean in a New York Medicaid context? Well, I use this chart, and you can think about it in a lot of different ways. You can think about it as the Medicaid population as a whole, all the different 6+ million people who are on the program. You can think about it if you're a financial person. You can think about it as the budget. This is the total expenditures, $59 billion that the program serves and spends on an annual basis. Or if you're a provider, perhaps you can think about it as services or subpopulations, individual people who need care and need different types of care. So the idea here is to sort of think about it holistically across the whole program, but break it into some more sort of definable and understandable parts. So I'll start on the left side of the chart. So this is where we provide, and we believe, much of the care needs to be provided and coordinated for the vast majority of the population. Not everyone can get their full needs in terms of care coordination met on this left side. Some of them need health homes, some of them need other forms of assistance because their needs are even greater. But for your average person on the Medicaid program, your average citizen in New York, we feel that an integrated physical and primary care setting where they're receiving high quality, highly coordinated care is the best place for them to get that services, to get that coordination, to get that assistance. Integrated into that setting also needs to be links to the other human services, the other social determinants of health. You know, individuals coming in with significant needs, primary physical care or perhaps behavioral health, may also have needs in terms of they're not signed up for food stamps. So as a result, the quality of their diet is low. They are substandardly housed or in fact are living on the street. How do you link that person to a housing subsidy, a housing program, someone who can assist them and get them off the street? Because it's very hard if you're a diabetic to manage your diabetes when you're living on the street. The answer is the only way you manage it is you manage it through the emergency room. Right? So we need to change that dynamic, so we need to integrate those human services also into this integrated physical and behavioral health setting. To us in New York, this is a big change, right? We have had a highly siloed physical and behavioral health setting. Now, here, our host here today is a good example of how you can integrate. They operate Article 28, Article 31 clinics, right? But the fact that we have separate licensure, right? You have to go through separate doors to get this is a clear indication of what we, in fact, the government has helped to do, which is to help reinforce the silos that exist between these two integral types of care. So that, and now what we need to do systematically is integrate those two at the point of care. So you got a one-stop shop where the providers are actually looking at the whole needs of the patient. I think this is potentially one of the most powerful things we're going to do with this. And why is because I think it gives us an opportunity to early diagnose people with behavioral health challenges and get them into some sort of treatment, redirect them away from what otherwise could be a real spiral down and lead to not only a poorer quality of life for them, but a tremendous amount of expense, which if we'd done something earlier, could have been avoided. So that's in essence the primary care setting, that's the community-based setting. And in the case of reimbursement for that setting, what we anticipate you would see is a mix of reimbursement. Some of it will be, and a core component of it, will be a per member per month payment. So members, patients assigned to clinics in that setting, they are receiving prospective payment. Why prospective payment? Well, now you have flexibility. You can, in essence, provide and fund things that traditional delivery system or traditional fee-for-service wouldn't cover. I sometimes call it the glue. It's the care coordinator. It's the person who picks up the phone and makes outbound phone calls to folks who missed their appointments. It's the folks who actually go out and do home visiting. For those individuals who don't. Maybe it's the transportation in a rural setting that otherwise wouldn't have been available so that you can get folks actually to their appointments. I think it's, when you move to that prospective payment, when you begin to break away from fee-for-service, you begin to have a lot more flexibility and you can design solutions unique to the needs of the patients you serve. So then we get to the right side. So you can think of that primary care, those community-based services on the left, but then we get to the other side. This is where you're really interacting with the delivery system. You're interacting with a more diverse set of providers. We can break these into bundles of service, and you could also look at subpopulations within this context. So I'll start with the services, and we'll start with what we call episodic. This is services that have a clear start and a clear end date. The classic example of this is maternity care. A woman is deemed to be pregnant, so that's the start, and then the end is either 1 month or 3 months postpartum. What do you care about during that episode? You want the most healthy birth possible, you want to minimize C-sections, and you want to make sure that that child starts off in the right way, and that the mother's health post-birth is as healthy as possible. So you give that family a tremendous opportunity for long-term success. In the case of this type of reimbursement, what you do is you provide these providers with a bundled payment, incentive for providers to work together to deploy new strategies to better improve birth outcomes. This is particularly important for the Medicaid program because in New York State, 50% of all babies that are born in our state, the Medicaid program is responsible for paying for those delivery services. So we feel that if we're able to transform the incentives to lower C-section rates, to improve birth outcomes, we could actually change how maternity care is provided for everyone in our state because of how significant we are as a payer in that area. Next up, you get into what I'll call the continuous services. This is where you come into the chronic diseases. These are diseases, things that people have throughout their lives. Our goal is to make sure they're getting the right mix of services to best help them manage their particular illness and keep them away from the sort of more acute services that are a result of poor management. This is where we're trying to avoid those ER visits. This is where we are trying to avoid the admissions, the readmissions for things like chronic illness that, if properly managed, are things that you don't need to be hospitalized for. And then lastly, perhaps most importantly for the topic for folks here today, is when we start talking about subpopulations. These are populations that are clearly definable, that have significant needs that cut across a wide array of services, a wide array of, sort of traditional silos in the delivery system. And what we want to do for those populations is this is really what we want to look at them holistically. We don't want to have a separate policy and a separate set of incentives for the people who provide primary care to those people, to the people who provide behavioral health, and in the case of developmentally disabled, to the people who provide all those waiver services that are so essential to the lives and well-being of those populations. We want those providers to come together. We want them to receive some form of bundled payment. Eventually, and I'll talk about when we get to what we call level 3 reimbursement. Very flexible dollars, so that then they can take a step back and say, okay, what are the needs of the developmentally disabled people in our community? How do we better design a delivery system that meets their unique needs? Not worrying so much about what the regulations have been, or worried about what the state payment policies are, what we pay for, what won't be paid for. But I think it's potentially very exciting evolution of this and benefit is the opportunity for some of these important subsets of the population, like the developmentally disabled, to sort of take a step back and say, really, what does the population need and how do we deliver it in the most cost-effective fashion possible? So in terms of this, there's lots of different, we call it the menu of options, ways in which this can be done. One could imagine, and maybe this is the best way to do it, is in certain communities that providers across that community can come together and say, you know what, for the patients that we serve, we want to be responsible for the full thing. We're bringing together people from across the entire spectrum. We're going to do the primary care. We're going to do all the episodic, we're continuous. We're responsible for total cost of care for a population. That means, I sometimes call those payments subcapitation or other types of payments. That means you take it on risk. You're responsible for performance, but you get maximum flexibility. There's some providers who, in fact, are doing that today. But there are other situations where you're going to have subsets of the delivery system, providers who want to contract separately for various elements of this. And that is also allowable under this model. What is the right model for each community is going to differ based on the needs of that community, how the providers are structured, what your history is. What's right up in the Adirondacks is going to be different than it's going to be here. What's different, and will be different than what is structured in the Bronx. So in terms of the levels of reimbursement, this gets into the amount of risk a provider takes relative to performance and also for total cost of care, is what's demonstrated on this chart. And this is important to point out. New York State, many other places have a long history of what's called pay for performance, which is providers billing fee-for-service. At the end of the year, we look at some outcomes. If you achieve some performance metrics, you get a bonus payment. That's nice, but I think the research clearly shows it doesn't really change fundamentally provider behavior. It doesn't lead to the kind of patient-centered delivery system that we want. And so in our world, that's considered level 0. It's not considered value-based payment. The minimum threshold, what we want to see as the default for Medicaid reimbursement, is where providers continue to bill fee-for-service, but at the end of the year, they have contracts in place that hold them accountable for both outcomes as well as for total cost of care for the services or for the people that they serve. And in the case of level 1, they're taking what's called upside-only risk. So if they generate shared savings, they achieve performance metrics, they get to keep a portion